All right. So part three, and this is actually our last part of our lecture, is about the DSM-5, so the Diagnostic and Statistical Manual, 5th edition. And this is important because throughout your OT career and also throughout your student career, flip-flop those, you're going to be looking at a variety of diagnoses. Now, me as a therapist, right, as a pediatric therapist and just a therapist in general, what I really want to focus on at the end of the day is whether a person can function, what they can do, what they can't do, functional limitations, functional strengths, etc. But in the big world, diagnosis is really important. It gets individual services. Yeah. In the schools, there's 13 different diagnostic categories, and you must have one in order to get an IEP, an individualized educational plan, and you must have a plan in order to access services. So, we learn about the DSM-5, which is all about mental disorders. And some of them are developmental, so it's not like mental disorders in terms of like a small sort of like schizophrenia and bipolar disorder, although it includes those, but it's a little bit broader than that. So we learn about it, even though we're still looking at function. I hope that makes sense. So we're going to use it because it's a very powerful tool, and also it helps us characterize and classify what's going on with a person, but it's not our only tool. And we actually act from a position and a perspective of function rather than diagnosis. So two people may have the same diagnosis, but have very different presentations. And as OTs, we're going to work on those different presentations. So two people may have autism, but one of them is really struggling with social skills and the other is really struggling with fine motor, right? So we're not going to treat them the same regardless of the fact that they have the same diagnosis. Yeah? Okay. So the DSM-5 was developed by the American Psychiatric Association. We are, in fact, in the 5th edition. It's changed a lot over time. Tends to be like about 10 years between editions. It gives us a common language and standard criteria for identifying different conditions. It's used by a wide range of health professionals, including OTs. Important to note that OTs do not diagnose conditions. We can think in our head, wow, that looks an awful lot like borderline personality disorder, but we are not the people that write it down anywhere or make that definitive diagnosis, right? And it also is used as a tool for collecting and communicating statistics. So how many people in the US have major depression? How many people have pica, which is eating non-nutritive substances, right? So we use it to think about numbers and statistics as well. Okay, and as I said, it changes over time. For example, we used to list being homosexual as a mental disorder, and thankfully that has been taken out of the DSM-5, and we no longer consider it a mental disorder. We used to have autism spectrum disorders, and there was 5 or 6 different subtypes, including Asperger's and a number of others, and now we just have this one diagnosis called autism 299.00 that has different features. So it's interesting because, you think like, well, there's just the diagnoses there are, right? But our way of describing them and our knowledge about them changes over time. And so the DSM reflects that. Okay. I love the DSM. Can you tell? All right. So there's 3 major components of the DSM-5 under any diagnosis. There's the classification, so the what is it, the diagnostic criteria set, how do we know this is it? And the descriptive text, which gives us a lot more information about a particular diagnosis. And we're going to look at each of those in turn. Okay, classification. So a diagnostic code or number is assigned to each diagnosis. This is important for insurance and also lets us know what is it that we're talking about. The codes are originally derived from the International Classification of Diseases 10th edition clinical modification, more familiarly known as the ICD-10. And you'll hear about that because that is all of the physical diseases. And the diagnosis is from the best match between signs and symptoms and available classifications. So we may not, when we're seeing somebody or when a psychiatrist is seeing somebody, they may not fit the diagnosis exactly, but we're going to do the best match. The second aspect is called the Diagnostic Criteria sets. So 3 aspects. This is the second one. It is a concise description of the disorder. It has specific criteria, and we're going to look at an example so you can see this. And then it will have this other piece, which is the differential or rule out diagnoses. So, for example, if we are seeing a person that's psychotic, right, we might think about schizophrenia, and they may in fact have schizophrenia, but they also might be taking drugs and have psychosis that's related to drug use. They might have a massive infection. We see this in older adults sometimes. If they have a UTI, suddenly their mental status is drastically altered. It may be due to fever. It may be due to a brain tumor, right? So what we want to do is to rule in and rule out before we decide on a diagnosis, so that we're making and when I say we, I mean people who, psychiatrists primarily, and psychologists. So we make the diagnosis that is the best fit. So we does not mean OTs diagnose. We simply means we as a team, okay? And we as professionals. And then finally, the diagnostic criteria increases diagnostic reliability. So when we think about all of the things that are specific to a particular diagnosis, it means that when we match them up with a person, our diagnosis, and again, this is the royal us, is more reliable. In other words, we can count on it more. All right, so that's diagnostic criteria sets. And basically, it's some pretty long descriptions of each disorder. The third part, is descriptive text. And this is as it says, a description of each disorder. It's based on many factors. The C below is our example, and it enables a differential diagnosis. So it enables us, this text, we go through and we read it very closely to determine diagnostic features, associated features, prevalence, subtypes, the development and course of the condition, risk and prognostic factors, and these are all in your presenter notes, whether it's culture-related, gender-related, all of that information. So the descriptive text can be pretty lengthy and very detailed. And again, it enables a differential diagnosis. So it enables us to make the clearest diagnosis that we can. All right, so following the slide deck, we will be looking at autism spectrum disorder, which is 299.00, and we're going to be using a PDF, which is linked in your presenter notes. I'll be pulling it up on the screen, and we'll look at this diagnosis, and we'll just do an overview of looking at these three different areas that go into the DSM-5. Congratulations, you've reached the end of the first lecture, and I will take a little break, maybe a musical interlude, and then we'll pull up the diagnosis and have a look at that. All right, thanks so much. See you soon. All right, so as promised, we are going to look at autism spectrum disorder 299.00, and if we're looking at the ICD-10, it is F84.0, and this is a PDF document, not the actual DSM-5, but it shows the three different aspects of how the DSM is organized. So for each disorder, let me get that squared away there. For each disorder, you'll have the title of the disorder and the number, and then you'll have a number of criteria that are associated with it. So for autism, and notice that this is very detailed and very wordy and can go on for quite a long time. So we're going to do a high overview, but I encourage you to access the DSM and actually look at the various diagnoses and dig in a little bit in your studies. Okay, so for autism, the first criteria, A, which is at the top there, is persistence deficits in social communication and social interaction across multiple contexts as manifested by the following: currently or by history. Examples are illustrative, not exhausted. See text. And if you'll recall, there's a section of text. So we're not going to go through all of these, but just to give you an idea, what they're saying is that it's social communication or social interaction. It has to be across multiple contexts. Like it can't be, oh, I go to a cocktail party and I have social anxiety, right? It has to be across a number of different areas. And it's manifested by the following: either now or sometime in the past. And then further, they're not saying like, these are the only ones. They're saying these are examples, and there might be other things that we left out. So the first one is deficits in social emotional reciprocity, ranging, for example, from abnormal social approach and failure of normal back and forth conversation to reduced sharing of interests, emotions, or affect, or failure to initiate or respond to social interactions. So that's just one little bit, right? Number two, deficits in nonverbal communication behavior, and they give a bunch of examples: eye contact, which we frequently associate with autism; body language. People with autism don't read body language well, and they don't often fit their body language to how they're feeling. And with this particular disorder, I may say people with autism using people first language. I may say autistics using language that autistics use for themselves. So please don't judge me too harshly or critically on my language, but dig into to what's underneath in terms of the DSM. All right. So number 2, this nonverbal communication, eye or body language, lack of facial expressions, or nonverbal communication. And then number 3 is deficits in developing, maintaining, and understanding relationships, ranging, for example, from difficulty adjusting behavior to suit social contexts, to sharing an imaginative play, making friends, or a lack of interest or overt interest in peers, right? So this is just one of the 3 categories. And then there's 3 different more specific behaviors or illustrations underneath. And then we specify the current severity. So it's based on table 1, which we'll go to. But typically we also are looking at how intense are these behaviors, right? And that accompanies all of the diagnostic criteria. The second one, B, is this restricted repetitive patterns of behavior, interests, or activities. And they specify here, note this, at least 2 of the following, right? Whereas above, it's saying by the following, currently or by history, so you have to have all of them. Here it's saying at least 2 of the following, currently or by history. And again, this caveat that it's an illustration, not an exhaustive list. So I'm not going to go through all 4 of these, but notice that there are 4. They describe them in detail, and then they ask that the severity be noted. We go on to criteria C. Symptoms must be present in the early developmental period, but may not become fully manifest until social demands exceed limited capacities, or may be masked by learned strategies in later life. So they're saying, you can't develop autism when you're 65 years old. It comes out early in development, but might not be really overt until you have to start using social skills. Symptom D is the symptoms cause clinically significant impairment in social, occupational, occupation, or other important areas of current function. So this is saying it's not enough to just have these symptoms. You actually have to be impaired by the symptoms. They have to be a problem for the individual. Okay. And then E, so this additional criteria is the disturbances are not better explained by intellectual disability, global developmental delay, or a number of other things, right? So this is the differential diagnosis piece where it's saying, hey, you might look like you have autism, but actually you have an intellectual disability or a global developmental delay, and they might look the same. So we need to differentiate which is which. Then they're further indicating that intellectual disability or ID and autism spectrum disorder actually go together often. They co-occur, and to make comorbid diagnoses of autism disorder and intellectual disability, social communication should be below that expected for the general developmental level. In effect saying, and I know this gets thick and heavy, that if you have ID, you actually have to have social communication that's more impaired than your level of overall disability due to compromised intellectual capacity. All right, finally, this note. People that have DSM-4 diagnoses of autistic disorder, Asperger's disorder, or pervasive developmental disorder not otherwise specified should be given the diagnosis of autism. And people who have marked deficits in social communication, but the symptoms don't otherwise meet the criteria, should be evaluated for social or pragmatic communication disorder. So remember when I said we used to have like 5 or 6 sub-diagnoses? Well, a lot of people were already diagnosed. So what do we do about them? Do we change their diagnosis? Yes. And now we decide, are they autistic? Or if it's really about social communication, do they have social pragmatic communication disorder, which is a different disorder? All right, getting to the end here. Then, after they meet the criteria, We have to specify, is it with or without intellectual impairment? With or without language impairment? Because some people have those and some people don't. Is there a medical or genetic condition or an environmental factor? Is there another neurodevelopmental, mental, or behavioral disorder? Is there catatonia? Then here's the table that they were referring to, and they're saying what is the severity of the social communication and the restrictive repetitive behaviors. And you'll notice that there are 3 different levels. So all of these figure into the diagnosis of autism. I hope this helps, and we will be discussing this further in class and can clear up any questions that you might have. Thanks so much, and we'll see you for the next video. Take care.